Hi, I'm JD Kalmenson, CEO of Montier Behavioral Health, and I'm joined by my colleague, Dr. Tiffany Joba, and we are thrilled to present to you Reconceptualizing Relapse Prevention, addressing the patient's unique needs in addiction recovery. And this is something that we at Montier are especially passionate about. It is a culmination of years of research, and we hope that you will find this presentation illuminating and effective. For your reference, the slide in front of you is a delineation of disclosures. Gaining perspective. The root issue that we'd love to discuss on today's presentation is something that is truly unfortunate in nature. As we continue to deal with COVID and its effects on our daily living, the numbers are staggering. In the United States alone, there have been 375,000 deaths from COVID, a true pandemic, and immense amount of resources and research have gone into play with a time-sensitive urgency to solve this very critical issue paralyzing society at large. But there is a lesser spoken about pandemic, which has not yet, unfortunately, garnered the same prominent attention and resources as that of COVID-19. And with that, I refer to the 93,000 deaths from drug overdose in the year 2020 alone. Unfortunately, our response as a society to this lesser spoken about pandemic is anything but encouraging. Whereas with other pandemics, as the years go on, as the research is developed, the resources are poured into solving the issue, the numbers tend to go down and the healing tends to begin. With regards to this national pandemic, the opposite is true. In the year 2019, there were 72,000 overdose deaths from overdose in the United States alone. And one would think that given the extreme nature of how much horrible tragedy is occurring as a result of these overdoses, we would get better, we would be smarter, we would be implementing more policy, more criteria into how this illness is treated. The opposite is true. And in 2020, the number has risen drastically, a 29% increase, in fact, resulting in the number of 93,000 deaths from drug overdose. And that is not including the suicide that results from the after effects and consequences of addiction. And a big portion of this failure is directly correlated to the industry relapse rates, because at the core of the situation are unforgivable high industry-wide relapse rates. As of 2017, we have in our country, in the United States, over 14,500 specialized substance abuse treatment centers that focus exclusively on treating chemical dependency, addiction recovery. And despite the immense infrastructure and resources poured into solving this epidemic, the success rate is consistently below 40%, which means that 60% of people who seek drug and alcohol treatment will relapse. So it is obviously something that demands our attention, and we have to realize what is it that we're failing to appreciate, to discern, that is causing such ineffective results in the intervention that is occurring in the treatment centers. One of the core issues that we're going to highlight today is the seeming inability to appreciate the incredible nuance and individual nature of this illness, of this disease. You see, when it comes to any other area of healthcare, any other malady and illness, it goes without saying that one seeks out a specialist who understands the individual nature of the issue. For example, when it comes to cancer treatment, oncologists will have to know at the very beginning, at the very elementary level of intervention, what type of cancer the patient has, when it began, what part of the body it is afflicting. When you compare that to addiction treatment, when you compare that to the bulk of what's going on clinically and psychiatrically in treatment centers around the country, there is a much more blanket approach taken to treatment, despite the nuances in the use, in the severity, and in the causation. And when that level of general vagueness and ambiguity is the standard, we will continue to see the unforgivable 60% of relapse rates. You see, individual care is not something new. Folks have been talking about it. Treatment centers are building their modalities, are building their treatment plans on individualized care, but it tends to be more or less of taking the same treatment and tailoring it to the individual versus appreciating the fact that the actual symptoms might be representing very different diseases, very different disorders, and very different underlying causations. As an industry, the consequences could not be more severe. Letting people down here have the highest stakes attached, with death, incarceration, and homelessness being just a few of the horrible ramifications of our failure to treat this comprehensively and successfully. I'd like to present to you as an example 3 case studies representing almost identical symptoms, which would seem to imply that they have the same illness, the same disorder, the same addiction, but yet, as we will hopefully highlight in today's presentation, actually reflect 3 very different pathways and causations to these symptoms, which really command individualized and separate forms of intervention, separate forms of treatment, which actually ensue and result in different expectations for what their aftercare and long-term sobriety might look like. Recognizing and discerning and appreciating the difference in these causations, the different types of intervention, and the different types of steps being put into place for aftercare will dramatically transform the efficacy of the sobriety and hopefully decrease the relapse rates very significantly. Take, for example, Sean Mitchell, fictional name, a fictional story. Sean, from when he was a very child, always recognized that he was different in the sense that everything that he would do that had an undertone of pleasure was very difficult for him to separate himself from, whether it was watching a movie and putting it down in the middle, or putting it down in the middle of the season, or even when he began to drink coffee. It wasn't just the one coffee, the way the rest of his friends, the way the rest of his social scene would drink that coffee. It was 4, 7 coffees a day. He was never able to put down a bag of chips in the middle. And when it came time for him, when it came time that he drank his first shot of alcohol, he was instantly hooked and addicted. And so went many years in which alcohol became replaced with crack, and then it was cocaine, and one drug led to the other. And now he's here at the brink of desperation, seeking addiction treatment, realizing that his life is not worth living if he cannot figure out how to free and liberate himself from the various vices and dependencies which seem to be taking out any meaning, purpose, and enjoyment. That's Sean. Our second case study for today is a fellow named Zach Gutierrez, who has a very different story. A beautiful, loving childhood, successful college years, graduates with honors, becomes a CPA, settles down for a 9-to-5 job, marries and has kids. Zach always wanted more out of life. He always felt that he can do more, but he would quell those feelings and manage to continue soldiering on, doing his job well, being a great husband, a loving dad, until something tragic occurred at the tender young age of 33. Zach gets into a horrible car accident, spends months in the hospital recuperating from excruciating pain. Given painkillers, and for the first time, being exposed to a substance, mind-altering in nature, Zach felt at peace from those feelings, from those desires and cravings to do something more in his life. And the painkillers that he utilized at the hospital quickly became a dependency, and even when discharged, Zach was hooked. And when he was no longer able to get his prescription, turned to the street for drugs and ended up becoming a heroin junkie. Last but not least, our third case study is a woman named Rachel Weiss. Her story, again, very different. She was verbally abused as a child, had a horrible upbringing, filled with neglect. And then at the tender young age of 9 years old, was sexually abused by a close relative, feeling intrinsic existential shame, with overwhelming feelings of inadequacy and pain, and not knowing what to do with them. She discovered cocaine at the young age of 13, and one drug led to the next, and she quickly became a junkie, dependent on opioids and benzos, and checks herself into treatment at 19 years old, knowing that this is her last chance at living life. Given these three case studies in mind, with their three seemingly similar symptoms of individuals who are dependent on drugs and alcohol, mind-altering substances, to live their life and are seeking liberation from it, let us explore with Dr. Tiffany how they might actually represent different pathways, different causations. And without further ado, I would love to pass on the mic to Dr. Tiffany.
Okay, thank you, JD, for covering that. Hi, everyone. I'm Dr. Tiffany Joba, and I am the Regional Director of Clinical Services for Monterey Behavioral Health. I've been working in the mental health and addiction treatment industry for the past 15 years. And where I'm going to pick up on is where JD had left off in terms of talking about the different pathways or causation of substance use, substance abuse disorders and addiction. And so as JD had mentioned in terms of cancer treatment and oncologists wanting to take a deep dive into how the cancer started, what type of cancer they're dealing with, where it's starting, what stage it's at, really looking very specifically at the disease in detail to know how to best approach treatment. And that's a lot of what we need to do initially with substance use disorder and addiction, is have a good understanding of what we're dealing with. And that starts with pathways or causation. And so we've narrowed this down to three general categories. We're going to find that individuals may fall into several categories. They may fall into two or three or even just one. But going back to the case studies that JD was talking about, we'll show how these individuals that he talked about, you can see very clear, distinct categories from which their substance use and addiction arose. So the first category we're going to talk about is that intrinsic vulnerability, or that predisposition. And what we're really looking at is this natural inclination towards addiction-like patterns. This very likely is a genetic predisposition. It can also lean heavily onto personality, having behaviors that morph into disorders such as impulse control behaviors and leading to very compulsive type behaviors. But you're seeing differences in the way that someone's brain works. You're seeing the neurobiology is different. You're seeing temperament is different. Personality is different. Maybe executive function deficits, self-regulation issues. In the case presentation of Sean, we see some impulse control disorders and some kind of addictive-like behavior across contexts with multiple, types of issues and different contexts. But really what we're looking at is somebody walking into this world with a vulnerability or predisposition towards addiction, whether that gets expressed or not. The second category that we see is addiction or substance use disorder that results as having access or availability to naturally very strongly addictive substances. So there are intrinsic properties of drugs that can lead to dependence, which leads to tolerance, which can then lead to addiction. So in the case presentation of Zach, we see somebody who, through access to opiates for pain management, then develops this dependence, tolerance, and addiction to opiates, which also fills the need for, feeling dissatisfied in life and having unfulfilling maybe goals or needs being met. But we're noticing that there are circumstances where somebody is put in front of a substance that is naturally very addictive, and then that leads to misuse, abuse, or addiction. The third category is a pathway or causation based off of a desire to self-medicate or attempt to cope. And this can be self-medicating or coping from disordered emotions. It can be disordered self-care and self-preservation, disordered self-esteem. We can see people using substances to cope with painful and threatening emotions, distress, suffering. Most of the time this shows up in trauma or trauma memories that surface. It can also be attempts to cope with, having an unfulfilling life, lack of meaning and purpose in life, or boredom. So in our case presentation of Rachel, it's a very good example of somebody who has pretty horrific childhood trauma in terms of sexual abuse that comes with all of the pain, suffering, trauma in which that individual would be using substances in an attempt to cope with things that are overwhelmingly stressful to the system. Along with looking at addiction, causation, and pathways that would lead somebody to develop a substance use disorder or addiction, we have to look at severity. So using that example of treating cancer, kind of that parallel process with treating cancer, and how oncologists would evaluate things is they're looking at stages of cancer, stage 1, 2, 3, or 4. With substance use disorder or addiction, we really need to look at the severity of that across a spectrum. And we do that by evaluating multiple factors. So one factor would be length of use. How long has somebody used? Is this something that has been problematic in the last year, 2 or 3 years, or has this been going on for 20 to 30 years? Age of first use plays a big role in this as well. So there's a difference in outcomes based on if somebody started using substances at 12 or 13 years old versus maybe 35 years old. We need to take into consideration things like tolerance, dependence, the type of substance, because there are going to be different properties, different intrinsic properties to substances that are going to play a role in how dependent somebody becomes on them and how they change the brain. And then looking at, are we dealing with multiple substances or one? The route of administration, how much has somebody tried to stop? How many unsuccessful attempts at recovery? And then, of course, we're looking at impairments in the following life domains. So we're looking at social, occupational, physical, psychological, legal, and recreational impairments. So putting all of these things together gives us an idea about how severe is this that we're dealing with. I had mentioned the different intrinsic properties of substances in terms of their addictiveness. naturally occurring on our spectrum from least addictive to most addictive. We have on the far right, tobacco or nicotine products, I should say, would be the most addictive. We also see that opiates, methamphetamines, extremely addictive. And then on the lesser end, we have alcohol. Not to say that alcohol isn't problematic, but not as intrinsically addictive in nature as opiates or methamphetamine. And then we look at what are some of the projected outcomes or expectations based off of this kind of individual assessment of categories that somebody might fall into, and then the severity of their addiction. So on a spectrum, in terms of somebody using alcohol or substances, we can have use, which would be casual, occasional, social, very limited and controlled, and recreational. We can have misuse, which is used for the purpose of altering a state of mind, getting drunk or getting high, but maybe doesn't have such severe consequences. Abuse would describe more of a frequent use in spite of impairment in functioning, and what looks like very harmful use. And then we have full-blown addiction, which is where we see that the brain is changed in very profound ways. You can see the way the brain is changed, you can measure it, it's long-lasting. We can look at the differences in activation in the reward center and notice how the midbrain reward center is activated in a way that overrides our frontal executive cortical functions. So things in the frontal lobe like impulse control and decision-making are dampened while the midbrain reward center is, lighting up and taking control. So in a true full-blown addiction where there's that compulsive use despite significant negative consequences, you have a brain that is changed in very obvious and measurable ways. So when we talk about addiction, the reason I want to highlight the severity of a true addiction and what we've kind of coined, or I've borrowed this term from Dr. Paul Early, of this addict brain, or you could say even the hijacked brain. The reason I think it's important to bring this forward is that when we're dealing with a brain that functions differently, that is altered in a different way, we need to use different interventions to address that. In our industry, this is one area where I think that we are falling behind in very significant ways. We have a plethora of research and evidence over the last 10 years at a minimum that shows that there truly is a disease and changes in the brain as a result of addiction. And yet in our industry as a whole, we tend to do the same things over and over that do not appreciate how the brain has changed, that don't take into consideration the ways in which the brain has changed. So addict brain, or the hijacked brain, is just a term to describe the process that happens when addiction rewires the brain. And what we're really seeing is that addiction is changing the way that one thinks, changing their motivation, changing learning, and changing behaviors in an effort to support ongoing use. So I mentioned the midbrain reward center being overly activated. What happens with this addiction process is that you have an intense, very unnaturally strong activation of the reward center that kicks in our primitive survival instincts. So the midbrain and that reward center is built to ensure the survival of the species. So it reinforces anything that would be tied up with a reward center. This can be food, this can be drinking water, this can be sex. So when we have substances, alcohol, benzodiazepines, opiates, methamphetamines, become linked and hooked up in that reward center, The brain interprets this as, I have to have this to survive. This is necessary for my survival. And then you have that reward center that is becoming louder and more in control than our frontal cortex, which is responsible for things like impulse control, decision-making, judgment. It's taking over in a way that isn't meant to be naturally. So the midbrain is not meant to be in the driver's seat. That is what happens in the process of addiction. And this is one of the things that we need to address or tackle in our treatment if we're looking at addiction, is what the person's truly dealing with. So in terms of learning and memory, that intense activation in the reward center of the brain, it takes a normally neutral cue, pairs it with use of alcohol or the substance, and starts to produce urges and cravings when that normally neutral cue is experienced on its own. So anyone who kind of studied Pavlov's dogs and understands how a bell could get a dog to salivate when it's paired enough times with the presentation of food, understands that cues, or what we call triggers, that are paired with alcohol use or substance use, start to produce those cravings and urges. So this can be sights, sounds, people, it can be places, times of day or times of the week, objects, or most commonly emotional experiences. We have neural circuits that produce compulsion, that wanting, that craving, that are activated by those conditioned cues, those triggers. So what happens is that, we have these kind of repetitive automatic behaviors that are established, and then the conscious interpretation of reality is hijacked. And this is where we talk about kind of the brain being hijacked by addiction. And this is why I reference it as either the addict brain or the hijacked brain. Along with that addictive process in the brain, you have a highly dysphoric phase in the absence of use, which is more reinforcing and encouraging for people to return to use. And then you have a desensitization of reward circuits, leading people to not be able to feel pleasure from normal rewards. So the normal things that used to be pleasurable are not pleasurable anymore, which again reinforces return to use. So when we have this process happening in the brain, once addiction is established, the brain is running on autopilot to support the addiction. This is really important for us to be attended to and attuned to when it comes to interventions that are unique and specific to the individual to keep them in recovery. So our assessments should be informed by neuroscience. Again, this is an area where I think that our industry as a whole is falling behind. We have the data, we have the research, we have experts and addictionologists who talk about the neuroscience of addiction and these processes that happen in the brain. And yet when it comes to where the rubber meets the road in treatment, especially in detox or residential treatment, or some of the more intensive treatment, we have a lack of paying very close attention to this and to tailoring our interventions and our aftercare around this. The brain is functioning in a manner that takes choice out of the equation. So just stopping is not an option, and willpower alone is not enough. This is where I think that, oftentimes practitioners struggle because we still have the language and maybe some of the policies in our industry that support, thinking that people have control and that they have options and that they can make better decisions. So when we're looking at truly the addictive process in the brain and that addict brain or that hijacked brain, what we see in terms of behaviors that manifest, we see denial, we see minimizing problems related to use. We see people who romanticize a substance or have very intense cravings, preoccupation with using, oftentimes engage in behaviors like manipulation and lying, behaviors that maintain the use, and then severe emotional dysregulation in the absence of use. So you can see how, one, a lot of these things create the context to make it very, very easy for a relapse to happen. But you also see that these behaviors at times to outsiders, to professionals, can look like resistance, can look like they're not ready, can look like they don't want treatment or they don't want to get better, when what you're really seeing is just the addiction in the brain playing out. So these different causations, these different pathways, understanding differences in severity, what are we truly dealing with? Are we dealing with misuse or abuse or substance use disorder? Are we dealing with an actual addiction that has changed the brain and the way that the brain works? These are all going to play into what our interventions are going to be. And so I'm going to cover with you all basic essential interventions that are important for treatment of substance use disorders and addiction. And these are all options that are evidence-based that we want to consider in terms of integrating into care, determining what do we think is going to be most appropriate for the individual based on what we know about them and what we've assessed. And what is a priority? What do we focus on first? So I'm going to start first with talking about medication-assisted treatment, MAT, as an intervention, as we just kind of got done talking about addiction brain or the hijacked brain, because this speaks mostly to how we address craving management and how we address those intense urges and cravings that come up from triggers when the brain is fully in that addict brain process. Now, most people assume that MAT means a maintenance of Suboxone, and that's just sort of what they've equated with that. But recognizing that medication-assisted treatment can look very antibinding based on the individual, and it can be the use of agonists. So medication that, antagonist, where it's medication that binds to the brain receptor to prevent the substance from accessing the receptor. Oftentimes I see clients who have multiple relapses and really intense cravings and find out that they've never used any antagonist like a naltrexone or a Vivitrol that might be able to help subside some cravings while also blocking the ability for them to get high off of a substance. We have our partial agonists that most people are very familiar with, the buprenorphine or Suboxone. And then we have the agonists which act in the brain the exact same way the substance does. So when somebody has a truly changed brain through the process of addiction, then looking at what options through medication-assisted treatment to help reset and recalibrate the brain, demonstrated to improve treatment outcomes. We're looking at helping to reset the reward center. So what you want to do in early recovery is give the brain time to heal, reset the system, control cravings to avoid relapse while somebody is in the process of working on everything else. So this is meant to be more time limited and to get people to a phase where they can start to heal the brain without having repeated relapses that compromise the brain. Another intervention, which is widely popular in addiction treatment and often utilized, is the 12-step support or some type of alternative support group. And I mention this because it is evidence-based. We do see It has a lot of clinical efficacy in terms of enhancing somebody's coping skills, enhancing their self-efficacy, improving their motivation, building healthy social networks. And the best part is it's free and easy to access for the long term, so people can have something that is stable and consistent over time to keep them connected. Now, everyone is different in terms of how or if they use this, but it's an option for an intervention that is evidence-based. Another important intervention is looking at how we address emotional awareness, emotional resilience, and distress tolerance. So when we talk about the pathways or causation, and especially looking at the case studies, one of the pathways or causation to substance use disorder or addiction that would be very relevant in addressing this area would be that desire to or attempt to cope and self-medicate. So when we have, individuals who come to us who have significant amount of trauma or have attachment injuries, negative core beliefs, they have painful emotions they're trying to escape, then part of the treatment process is one, making them aware of their emotions, building emotional resilience, and building distress tolerance, so that they can learn how to manage some of the trauma and manage the uncomfortable emotions, manage stressful situations without needing to rely on alcohol or drugs to soothe that or cope with that. We're helping individuals recognize the emotional connections that they formed with alcohol or substances. We're helping them understand the disconnection that may have happened from emotions, or how they've numbed out and avoided uncomfortable emotions during the process of their use or their addiction. We're helping them to learn to sit with uncomfortable emotions without needing to return to use. DBT is very, very effective with this. And oftentimes people equate DBT with treating borderline personality disorder. It's actually very effective in treating substance use disorders and addiction. We're helping clients accurately perceive the emotions that they're experiencing, regulating emotions, building tolerance to stressful and uncomfortable feelings, and then being able to combine emotional content with rational thought when making decisions about their recovery. Another intervention is changing the overall life story or the overall narrative that our clients come to us with. Trauma, attachment injuries, abandonment, neglect. These are all things that happen in life that can leave individuals with a core belief system that's negative, a core belief system that is promoting behaviors that can be reckless or put them in danger, promoting shame. So what we want to do is, using CBT or narrative therapy, help clients evaluate their life story, examine it, rewrite it, replace self-sabotaging stories with those that promote health, examine shame and the effects of shame on their view of self, others, and the world, work with their resistance, help them understand and deepen their appreciation of defenses that keep them from accepting or addressing their illness. So this is an important intervention for those who really struggle with these negative and destructive core beliefs or life narratives. And then we have connection and spirituality, which are essential interventions for helping people in the process of their recovery. Connection is a part of the healing process where we're reconnecting clients with others, building that support system, developing healthy attachments, helping them to develop healthy interconnectedness with others. working on repairing attachment injuries, forming healthy bonds, and helping them learn how to have basic healthy interpersonal skills. In terms of spirituality, a really crucial intervention is helping to assess, what is the client's belief system? What is their worldview or belief, and how can that act as a resource for them in recovery? For some individuals, their worldview or their belief system might be contributing to more shame. So how do we assess and kind of pick that apart and evaluate that? We want to help clients develop a sense of meaning and purpose, evaluate their value system, and then align their current lifestyle and their values with their core authentic self. So in terms of post-traumatic growth, there is an overwhelming amount of evidence to show that, helping clients to dig through and explore concepts like forgiveness, meaning making, and purpose are hugely instrumental in finding post-traumatic growth, that they create an overwhelming amount of resilience when you're able to do that. We also have couple and family therapy as an intervention. I know that this is often something that's pushed in different treatment arenas, although sometimes it might be overlooked or not fully appreciated, but we want to make sure that we recognize that everyone in close relationship to the client is affected by or affects the client's addiction. They can play a role in supporting recovery, or they can play a role in inadvertently maintaining the illness. So part of doing that systemic kind of, conjoint therapy is assessing dynamics, providing psychoeducation to people who are key players in that individual's life and promoting healthy boundaries, helping families and couples heal and rebuild trust, and establishing how key players in a person's life can support their recovery in the home environment and what they need to do in case of a lapse or a relapse. And then relapse prevention is a critical intervention. I know this is one that is commonly used in different treatment centers and often kind of pitched as the main or the prominent intervention. It's an ongoing process that starts at detox, starts the moment that you start to help somebody in their recovery, and it continues through to outpatient and should be an ongoing endeavor. And this is where we're looking at identifying what are some of those condition cues that we talked about before with the addict brain. What are the triggers, both internal, meaning emotional, and external, meaning environmental. Training clients on using coping skills, practicing their coping skills in a contained setting before they're needed, identifying protective factors, and then identifying high-risk situations. So what are some things that are going to be more triggering for them? Structure, schedules, and goals are a huge part of relapse prevention. And then when we have individuals who tend to have multiple relapses over and over, we should be doing a very thorough relapse autopsy to identify what's working, what hasn't worked, what are we missing, what are some of the pitfalls, and have new strategies moving forward so we're not doing the same thing over and over again. So we don't have a client in treatment for the fourth time and we're trying to use the same interventions and the same approaches that didn't work the first 3 times. And from here, this is where I'm going to pass it off to JD.
Thank you so much, Dr. Tiffany, for that very illuminating insight into the various pathways and causation and into the very different and distinct interventions to maximize the efficacy. Going back to our case studies, just to bring this home for a moment. So we now go and look at an individual like Sean Mitchell, for example, and we're able to appreciate that there is some genetic predisposition that makes this individual particularly susceptible to poor impulse control. and to dependency in all forms and fashions. So for somebody like Sean, all drugs, regardless of drug of choice, would have a similar appeal, would have a similar danger and vulnerability. Whereas, for example, with somebody who was exposed to a certain type of a drug under certain circumstances and doesn't have the same predisposed genetic susceptibility to all forms of dependency, addiction, abuse, and poor impulse control, it might be that one drug, for example, that is a trigger, and that is what they have to be very wary and mindful of in abstinence and in their long-term sobriety plan. And this really accounts for, the diversity that we see within folks who are sober, where you have the total abstinence model championed by the 12 steps and other support groups. And then you have folks who are on the medication-assisted treatment or might have struggled with a drug of choice such as heroin or opioids or benzos, but still don't necessarily have an issue with recreational marijuana. And then you have others who, a can of beer after 5 years of sobriety might set them back. And we look at this level of this range of diversity within recovery, and we try to make rhyme and reason out of it. But based on some of what was just shared by Dr. Tiffany, this becomes very clear, this becomes very understood, because context is everything, and the specific cause and pathway that led these individuals to their dependency, to the use or abuse or disorder, is vital in understanding what the pathway out of it might look like. And so, for example, Rachel Weiss, whose mental health trauma and abuse that she suffered as a child led to her seeking out mind-altering substances, it is so vital to understand that for her, the drug wasn't for the high, but it was rather to escape the pain, to numb the pain, to silence the pain. And therefore, something that would be vital and indispensable to a long-term recovery plan for her to prevent relapse would be to really place the mental health intervention and component as a priority, a residual relationship with her clinician, pursuing a modality of treatment, whether it would be the talk therapy, DBT or CBT or EMDR or whatever was helping her alleviate the pain and help her process the trauma. That is obviously something that, even though it is rooted in mental health in a primary way, has an inextricable link to the dependency and the pursuit of mind-altering substances to escape that pain, because the absence of alleviating that pain in a healthy manner would reignite that dependency to relieve the pain in an unhealthy and toxic, dangerous manner. And then, for example, we go to Zach Gutierrez, which seems to be more nuanced, because even though these pathways are distinct and different and can't present themselves as completely independent one of the other, somebody like Zach, who was always looking for something more in life and struggled to find meaning and purpose in his particular 9-to-5 job, but never did anything about it and still managed to maintain the facade of functionality. But then when that was coupled and accompanied with circumstances of available substances, such as the painkillers that were given to him when he was in the hospital, that combination proved to be particularly dangerous for Zach, because for the first time, he was able to get rid of those feelings of emptiness by being in a mind-altered state of being. And that was the particular appeal for him. So for Zach, we have an interesting overlap of availability and circumstances coupled with a need to medicate, where in his case, it was to medicate from his intrinsic desire for meaning and purpose, which he wasn't finding. And that combination led to his dependency. So now we look at the slide in front of us, and based on those unique pathways and causations, we right now find unique pathways of treatment. Taking the varied factors of addiction into account, the diverse path towards sobriety becomes crystal clear and indispensable to the efficacy of the treatment. So for somebody who is struggling with meaning and purpose and is looking for some increased spirituality connection in their life, a 12-step program would be particularly helpful for them, or other forms of existential therapy, whether it's logotherapy by Viktor Frankl or other positive psychology interventions. And then you have the poor impulse control, the predisposed, pre-genetically disposed susceptibility towards all forms of pleasure. So the medication-assisted treatment would be particularly helpful. Understanding emotional resilience and understanding the nature of, of pause between stimuli and response, and the need to take stock of emotions and to be able to find a pathway to halt the block of the impulse would be something particularly relevant for Sean Mitchell in his example, who suffered from a predisposed susceptibility to all forms of addiction and dependency with poor impulse control. For somebody like that, the total abstinence model championed by the 12 steps can be enormously helpful in understanding the unique nature of somebody with that type of predisposed vulnerability. Finding this support, finding like-minded individuals, and subscribing to that rigid model might be the most effective platform for sustainable sobriety. Taking all of the above into account, what we've done at Montefiore, led by Dr. Tiffany, is we've created a scale, and we call it the discovery scale, to help cut to the chase and to help peel away the layers of this onion to figure out the causation or causations if there is overlap, and to be able to understand the real individualized, unique nature of the disorder or the abuse or the misuse that each and every client who's in front of us is suffering from, so that we can accurately prescribe the correct intervention. So without further ado, I will pass it back to Dr. Tiffany to explain and to elucidate the scale that we've put together.
Okay, thank you. JD did a great job explaining how we're going to look at individual assessment and individual needs of every client who's coming into our care and determining what interventions are going to be most appropriate for them and the interventions we want to prioritize above others. Maybe we'll use several, but we'll prioritize certain ones first. And moving away from the, traditional approach, which is either everything, plus a kitchen sink thrown at every single client, regardless of their unique needs, or, one specific prescribed approach to recovery, such as a 12-step model or a social model approach, prescribed to every single person. What we're doing is looking at the uniqueness of every individual based off of the causation, the pathway, the severity, what their outcome is, and what they're needing. At Montefiore Behavioral Health, we've put together this discovery assessment, which guides a clinician into evaluating what are the specific circumstances for every client, historically and current, and what are their unique needs. So it's everything that we've already been discussing, just formalized in a way that's very structured to help guide the clinician and individualize treatment in a way where we're truly, truly looking at those specific qualities and needs. So this discovery assessment, a clinical tool that will guide decision-making with which interventions are used. Again, the priority of these interventions, because it may be that we want to get to certain interventions down the line, but we understand that we have to focus first on one or two interventions to establish a foundation, to establish safety. Maybe these need to be taken in steps. So something might be an intervention in detox or residential treatment. And then the recommendation would be maybe an intensive outpatient or outpatient therapy, we get to other interventions down the line rather than trying to tackle everything at once. Our clinical assessment tool is also going to guide our aftercare recommendations. So we're not going to do a blanket recommendation for every single client that looks identical. We're going to decide based off of these nuances and needs of clients what makes the most sense for them. So we're looking at, in this assessment, identifying what are some of the causations or pathways that led to the use, abuse, or addiction that we're looking at. And what is the severity? Where does this person fall on this scale or on this kind of trajectory? And what are their specific individual needs? What are they struggling with? That may come to looking at, if they've attempted to maintain their own sobriety or recovery in the past and have failed, if they've had multiple relapses before, they've been unsuccessful, what were some of the things that were missing, or what did they need that did not get addressed? So we want to make sure that individualized treatment is informed by understanding, do they have this intrinsic vulnerability or this predisposition? Was this prompted by access or availability to substances that are intrinsically very, chemically dependent? Or was this, and maybe a combination of many, is this an attempt to self-medicate or cope with something that is overwhelming that most people would not be able to manage? So getting deeper into the categories of causation. And so in this assessment tool, we're prompting clinicians, first of all, to focus on very specific historical and current evidence of intrinsic vulnerability or that predisposition. So we're prompting clinicians to identify, is there a strong family history of addiction? Going back to everyone in their immediate family, their extended family, do they have others in that family lineage who have struggled with addiction issues, even if it's other types of addiction, maybe a food addiction, a sex addiction, a chemical dependency, whatever that might look like? Is there a strong kind of genetic heritability of that? Has that client struggled in other areas with impulse control and with regulation? So, similar to one of our case presentations, do we see that this is somebody who has a hard time controlling themselves with a lot of different things? It could be that they have a hard time with impulses with food, with sugar, maybe with sex or pornography, or with gambling. So we're looking at, does this show up in other areas of life? Really, are there other addictive behaviors that are present? And then we're also looking at, is there any evidence of maybe some differences in how their frontal lobe is functioning compared to other people, or any evidence of any frontal lobe dysfunction? So is this someone who has difficulties across the board with impulsivity, with decision-making? Is this someone who has difficulties with, focused attention? Any of those kind of things that might suggest that there are some neurological differences that might be at play as well. Then we move on to looking at, is there any historical or current evidence of the addiction or the use, misuse, abuse being prompted by access and availability to substances that are intrinsically very addicting? So this is looking at, when did the use start? Is this something that started, for example, after a car accident with a prescribed medication, prescribed painkillers? Is this something that started when somebody got to college and their peer group normalized the excessive use of alcohol, or maybe normalized the use of things like ecstasy or cocaine, something along those lines. Was it something that started as casual and recreational and then escalated? So the peer group and those around them would say this is normal and acceptable, but it escalated to the point that it was problematic and out of control. So looking at, when did this start? Are there contextual or circumstantial factors that led to the use? Whereas if, let's say, this individual never had that circumstance or that context arrive in their life, they maybe never would have ended up with any type of problematic use or addiction. For example, if there was never the car accident, which led to the prescription, they probably would not be a heroin addict. Or if this wasn't an individual who maybe was in a community or a subculture that normalized the use of methamphetamine, then they wouldn't have ended up with that type of addiction. So really looking at that access and availability as being the route leading to the use and addiction. And then, of course, focusing on historical or current evidence of substance use as an attempt to self-medicate or cope. So were there mental health symptoms that preceded the use? Is this somebody who has maybe depression, anxiety, OCD in their family, family history of bipolar disorder, some type of severe mental illness where they're struggling with pretty severe mental health symptoms, and using alcohol or a substance is a way to escape some of that symptomology or to relieve some of that symptomology. Did we see use in the individual following some childhood trauma or traumatic events, or as a way to cope with trauma memories that continue to surface? So, did the person we're dealing with have significant childhood trauma or ongoing developmental trauma? Were there attachment injuries, chronic experiences of neglect or abandonment that would lead to the desire to self-medicate to cope? Are they attempting to cope with suffering? And is use an attempt to feel something that they're unable to feel when they're not using, when they're sober? There are some individuals who just walk through life feeling numb and disconnected, and then they have an experience where they use a mind-altering substance and suddenly they feel euphoria, they feel joy, they feel alive. Is that really what is at play? So this assessment, again, is prompting the clinician to assess for all of these individual areas and to look at, where is this client falling? Is it one category that's very dominant? Is it a couple that are both very relevant? Or is it all three? What are we really dealing with? Then we're prompting clinicians to focus on additional factors that may be at play. So this is where we're looking at, where does this individual fall in terms of that addiction severity spectrum or use severity spectrum, along with what are their treatment needs. So first of all is assessing the severity. What are we really dealing with? Most of the time when clients reach the point where they have to be in treatment, it's gone beyond controlled or social use. So this is probably not where we're going to see clients. However, you may have a client who has experienced legal issues in regards to using. Maybe they were a college kid who's caught in possession of something that was used recreationally, and they're mandated a treatment. So that could be a case where you might find somebody who has more controlled social use, recreational use that has gotten them into certain problems or their mandated treatment. It's going to be more rare, but it's possible. More likely, we're going to see a lot of individuals who have use that falls into the harmful use category. You can have individuals who suffer pretty significant consequences from alcohol use or drug use that don't actually have, what we would consider a full-blown addiction. They have a negative or toxic relationship with alcohol or drugs. They've had problems in relationships, maybe legal problems, but it hasn't changed the brain in a way where we would see with a full addiction. So we're going to be dealing with a lot of clients that fall into that category in terms of severity. And then we're also going to be dealing with a significant number of individuals who experience what I described as that hijacked brain or that addict brain, where that full-on addiction process is at play. And we're not just dealing with all of the consequences of addiction. We're dealing with a brain that is functionally and structurally different than somebody who does not have an addiction. And we need to take that into consideration when it comes to assessing their needs and looking at individualized interventions and aftercare. So it's, risk of use, types of substances, age of first use, duration, consequences that all go into determining what is the severity, what are we dealing with? And then when it comes to needs in terms of factors to consider, craving management. If this is an individual who has had multiple relapses after attempting to maintain sobriety on their own, they have made an active effort to stay away from alcohol or substances, and they continue to relapse. What this tells me as a clinician is that cravings are not being appropriately managed. That, especially if this is someone who's actually trying and desiring, and we explore the relapses and they tell me that, they experienced triggers and the triggers led them to get back to drinking, or they were not really sure. I don't know. Something happened. I thought I was doing okay. And the next thing I know, I ended up back at the bar, and I couldn't tell you what happened from point A to point B. It gives me information that there are urges and cravings that are going on that are not being managed. And so we need to look at either how do we manage cravings, or how do we address the triggers that produce the cravings, usually a combination of both. So with craving management, obviously using medication and treatment is a great way to address craving management and help give people more control. But some of the relapse prevention strategies can address the triggers, which then can reduce cravings, because if you get control over triggers and help kind of widen the gap between what happens when somebody is triggered and when they run on autopilot with their kind of craving behaviors, and we can help to manage that as well. Is this somebody who needs support and accountability? And, in the industry, I think it's sort of a blanket expectation that everybody should participate in 12-step support groups, AA, NA, or some type of community involvement in that way. And there are people who desperately need it, that's what's lacking for them, that they will tell you without accountability or without a group of people to support them and to hold them, responsible and accountable for showing up, that they likely would not do well in their recovery. And there are others who don't find it necessary, or who are turned off by it or find it counterproductive. So it's really assessing, again, what are the individual needs, and is that something that is effective for that individual? It's not a blanket, this works for everybody. We have to assess individually whether that's appropriate or not. And then looking at, what is this person's ability to maintain control over their emotions, to understand their emotions, to tolerate stress and distress? Is that something that this person needs to focus on? If you know that an individual is constantly being triggered and having cravings to return to use based off of emotional experiences, that every time they feel lonely or every time they feel depressed or they feel shame or any negative emotion, that they are instantly compelled to, go back to alcohol or return to substance use, then we know that we really need to get a handle on their emotion regulation and distress tolerance, that would be an important place for us to start with them, that the emotions and inability to regulate and tolerate those are driving them, are creating intense cravings and driving them back to use. You can't expect people to walk through life never experiencing any negative emotions or any stress. That's a part of the human experience, experiencing negative emotions. So it's teaching them how to deal with that, how to manage that without that crippling them and collapsing them. We also want to look at, are there thought patterns, are there belief systems, these unhelpful cognitions that are triggering some of these cravings and relapses? So it could be someone's walking through the world with these negative core beliefs that continue to sabotage them over and over again. So it could be that one of the primary interventions that we need to look at first is, how do we help somebody to reevaluate these belief systems, to challenge the distorted thinking, to challenge the shame? Of course, connection and then the spiritual element may also be critical components to, in terms of what a client needs to establish and sustain recovery. If this is somebody who is feeling disconnected and lonely and without meaning, without purpose, without anything that really grounds them, then it's very likely when they're out in the world that they're going to feel this perpetual emptiness that, again, will be a trigger that will lead to cravings, that will lead to relapse. So for a lot of individuals, part of, establishing something that is more powerful than, the triggers or the cravings, is having that deep connection or that alignment with the spiritual self or with these kind of existential principles, meaning and purpose being the primary. We also need to assess, does this client need to do couple or family work urgently in order to prepare them to be kind of back in the environment with people who could be inadvertently enabling or sustaining use, or could be triggering. So if somebody has a primary relationship that has been contributing in some way or another to their ongoing use or to their relapses, then you can do all of the great individual work that you want, all of the breakthrough, powerful psychotherapy that you want with the person while they're in treatment, and then you send them back home to an environment that is chaotic or negative or toxic or threatening to sobriety, and you find them relapsing over and over again. So this is an important part of the work for some people. And then, of course, relapse prevention strategies, which for the most part is going to be essential for most everyone across the board. It's just a matter of, how much emphasis do we place on this and how important is this? For some people, it's going to be one of the primary interventions that needs to be addressed. And for others, it will be something that would be adjunct, but not the central core intervention that we're going to be focusing on. So again, looking at oftentimes you get a good idea about needs based off of what hasn't worked in the past, or where people have gone wrong in the past, or what's been lacking for them previously. And with that, for our conclusion, I will pass it back to JD.
Thank you so very much, Dr. Tiffany, for that comprehensive, thorough, and detailed explanation of the discovery assessment. And in conclusion, and in looking ahead, we are hopeful that with tools and assessments like the discovery scale, which will help enable us to truly discern and excavate the individualized nature of addiction, we will dramatically decrease the relapse rates, which will dramatically decrease the drug overdoses and the death. If anything has emerged from this presentation, it is the simple notion that the intervention has to be individualized based on the cause, based on the pathway. The nature of that intervention will become so much more effective, so much more helpful when it truly understands the nuance and the differences and the intricate differences of severity, of use, of causation. You see, for example, if you have one fabric, then you're not really individualizing the suits that you make as a tailor. You're just customizing the size for the different clients who walk through your doors. Truly individualizing the apparel would be to give them the option of a difference of fabric and texture based on the use, based on their desire, based on their preference. And that is really what the scale is hoping to achieve in behavioral health for those who are suffering with chemical dependency, to be able to understand that symptoms might be similar, but the nature of what they're suffering from can be dramatically different. And based on a different intervention, the aftercare becomes so individualized, which puts them on a pathway for success in understanding what triggers might look like. And we all know that triggers lead to relapse, and relapse leads to drug overdose. So if we can help the Zach Gutierrez's of the world, the Rachel Weiss's of the world, or the Sean Mitchells of the world, and be able to appreciate the individual nature of what they're suffering from, we can truly change the landscape of addiction recovery. And even if that process is slow, just to conclude with the story that we all know about the child who is on the beach throwing starfish back into the ocean. And the older fellow who's walking by is somewhat cynical and asks him what he's doing, and he says that he's saving the starfish. And the old man looks at him and says, "But young lad, the beach is filled with hundreds of starfish. And then the next beach over, which is even larger, has thousands. And there are thousands of beaches across the coastline. How can you possibly think that you're making a difference?" And to which the young boy said, as he threw that starfish into the ocean, "To that one, it sure made a difference." So in conclusion, as the Talmud says, he who saves one life has saved the entire world. We hope that with this increased knowledge and awareness, with this increased level of attentiveness to detail, with platforms and initiatives like the Discovery Scale, we can save the world one life at a time. Thank you so much.